So we're going to continue on here, and hopefully it'll be okay. So I'm going to finish up the structure of this here. Respiratory membrane, where the all the lovely things come together: the capillaries, the arteries, the alveolar sacs, all that kind of stuff is called the air-blood barrier. All right, thin squamous epithelial layer lining the alveolar walls. Pulmonary capillaries cover the external surface of the outlet. That's how you wrap alveoli. And if you look on page 444, you see a really good picture of these kind of wrapping together on the thing in here. And there's that air-blood-borne barrier there. You have the surfactant, the secreting cell, squamous epithelial cell on the actual alveolar wall. All right, and you have macrophages in there to help with bacteria stuff. There's the respiratory membrane coming in here, and right along this line, like there's the capillaries coming in here into this area. You have this blood, air blood things. The oxygen comes in here to get to the blood. This is where the capillary changes its shape and releases the CO2 back into the alveolar, and they kind of go back and forth, and that's how the gas exchange takes place. At least that's where it does. Okay, so gas exchange. Gas crosses the respiratory membrane by diffusion. Okay, it is simply a diffusion process, high concentration, low concentration. Oxygen enters the blood, carbon dioxide enters the alveoli. Macrophages add protection, like I said, to help with bacteria. And surfactant coats the gas exposed alveolar surfaces. That's where that moisture comes in and helps the stuff to smoothly move around. Okay, now the events of respiration, the actual process itself. There are different names for a bunch of these things. Don't panic. It is what it is. We just do our best. Pulmonary ventilation is simply moving air in and out of the lungs. Okay, so actually getting air in from the outside and out of the lungs. It's also known as external respiration, the gas exchange between the pulmonary blood and the alveoli. So as we get down to the idea about doing all of these respiration processes. Respiratory gas transport, transport of oxygen and carbon via the bloodstream. And internal respiration is where gas exchange between the blood and the tissue cells. All right, so we go back to this one right here. This is where the gas exchange between the blood and the alveoli, the lungs and the blood. All right, moving air in and out. Okay, that's the outside one. And then this then gets it inside the bloodstream, is that respiratory gas transport. And the internal is where the gas exchange between blood and the tissue cells in the capillary. So this is when it gets into the muscles and into all that kind of stuff to give them the things that they need. All right, in that aspect. Okay. Mechanics of breathing, the actual pulmonary ventilation, getting air in and out of the lungs, is completely mechanical. It simply depends on volume changes in the thoracic cavity. Volume changes lead to pressure changes, which lead to the flow of gases to equalize pressure. So go back to chemistry and all your great knowledge with that. All right, and go back to Boyle's law. P1V1 equals P2V2. They were an indirect relationship. As the volume expanded, the pressure dropped. Okay, they were indirect. As the volume shrank, the pressure increased. So what happens is we need a volume change that leads to a pressure change. So what's going to happen is we need the area of the lungs to expand. That volume expands, which drops the pressure. And then by simple balancing, outside pressure, inside pressure, air is pulled in from the outside to equalize that pressure. Okay, so that's all goes back to chemistry and Boyle's law, understanding how pressure and volume are related. If you don't remember that, it's okay, but just give you a little review about how that stuff works. Okay. There are two phases of this. Obviously, you're going to have inspiration, which is the flow of air into the lung, and expiration, which is the air leaving the lung. So in order for this to happen, the volume has to expand, and therefore the pressure will drop and air will then come into the lungs. And expiration happen, the reverse has to happen. The diaphragm will push back up, collapsing it, creating a greater pressure inside than outside, and then the air goes out. This is the lab that we were going to do. All right, it was the build a lung lab. We take a bottle and a little Y adapter, make balloons out of it, and all that kind of stuff. But you pull on the bottom, and that acts as your diaphragm, pulling that up, opening up the space, decreasing the pressure, bringing air into the balloons, into the lungs. Okay. Diaphragm and intercostal muscles are what are in control of that. So again, go back to that first picture with the diaphragm at the bottom. Diaphragm and intercostal muscles pull down and out. So just take a deep breath in. You can feel it in your chest and your stuff and all that kind of stuff. The size of the thoracic cavity increases. External air is then pulled in the lungs to balance out the pressure and increase in interpulmonary volume. So we're bringing stuff into the actual thing like that. So here's a picture of it. All right. So the idea here during full inspiration, this is going to expand. Diaphragm moves inferiorly, coming down. The ribs elevate as these contract, opening up this entire thoracic cavity and then bringing air into the lungs. All right. Exhalation is largely a passive process. It depends on natural lung elasticity. As muscles relax, as the diaphragm, you can hold your breath as long as you want, but eventually the diaphragm's got to collapse back in. As the muscle relaxes, the air is pushed out by the lungs. Forced expiration can occur mostly by contracting internal intercostal muscles to depress the rib cage. What that means is if you go to the doctor and they tell you to take a deep breath in and then blow all of your air out, your body doesn't necessarily want to blow all of the air out, so you have to force it. You got to contract these intercostal muscles to continue to blow and blow and blow. I had to do that with the asthma test that I had a couple weeks ago or a couple months ago. I had to see whether I actually had asthma or not, and it was forced air coming out. Okay, so again, this relaxes, the space comes back in, the things flat back down, and then the elasticity of the lungs shrinks back down. Okay, nothing terribly difficult with all of that. All right, non-respiratory air movements, things that happen that are not part of breathing, all right, can be caused by reflexes or voluntary actions. So obviously we talked about coughing, we talked about the ciliated action, trying to put that stuff out. That has nothing to do with breathing. That's a ciliated motion trying to get stuff out. Laughing, crying, yawning, and hiccuping are all part of these things as well. A hiccup is simply a gas bubble trapped, excuse me, speaking of coughing, a gas bubble trapped underneath the diaphragm as this air is being taken in. And your body doesn't really know what to do with it. So it tries to get it out that way. But laughing, crying, yawning are all part of things that will induce you to breathe in and all these other kind of stuff as well. Okay. Now, respiratory volumes and capacities. Normal breathing moves about 500 milliliters of air with each breath. That is called the tidal volume. Tidal volume is your normal breathing, what comes in. Many factors can affect respiratory capacity. Person size, obviously the bigger you are, the more tidal volume you're going to have. Sex, men typically tend to be bigger, so therefore have bigger lungs, and so they're bigger, have respiratory capacity. Age, this is going to be the reverse. As the older you get, the less you're going to have, mainly because the alveolar sacs are damaged as you get older, and so you just can't take as much air in. And then obviously your physical condition. You're really obese, you got a lot of weight sitting on top of there, harder for the diaphragm to expand, therefore harder to get air in. Okay. After the tidal volume, that 500 milliliters of air, you have what's called residual volume, the air after exhalation. About 1,200 milliliters of air remains inside the lungs, okay, at all times. Unless, again, you're doing a test where you're trying to blow all that stuff out of there. We have inspiratory reserve volume, the amount of air that can be taken in forcibly over the tidal volume. So you just try to bring in as much as you can. And then you have the expiratory reserve volume, the amount of air that can be forcibly exhaled. It's about that 1,200 milliliters that you had left in there. You can try to get rid of all that stuff as much as you can. So normal breathing, 500 milliliters. Obviously, if you're taking a big, deep breath and trying to do this kind of stuff, you're going to try to force in more than you normally take in just breathing. Okay, and so you can expand that greatly as you do this, but obviously then you can pull back and get rid of the expiratory reserve volume as well. Okay, and again, residual volume is just that 1,200 milliliters that should stay in there after you expire the air. So what we look at is 100% called the vital capacity, total amount of exchangeable air. Vital capacity is your tidal volume, your expiratory reserve volume, and your all that ERV as well. So you have the dead space volume, air that remains in conducting zone and never reaches the alveoli, about 150 milliliters. It just doesn't get all the way down. You breathe it in, it's on its way down there, but by the time you do that, you breathe it out. Okay, which is where we're going to talk about hyperventilating later on. Okay, functional volume, air that actually reaches the respiratory. So if you're taking in 500 with tidal volume and 150 doesn't get there, usually about 350 milliliters it gets there. Respiratory capacity is what's called a spirometer. So when my dad went through his heart surgery, one of the things he had to do is he had to use the spirometer all the time, trying to get his number up to that 350 milliliters, trying to get that tidal volume to get better, because with the surgery on the chest and the idea of collapsing those lungs coming in there, you got to retrain and almost to expand and contract and trust your body to do this. So here's a little chart about how much you can take in your inspiratory reserve volume. Here's your normal, the tidal volume. Here's your expiratory reserve volume, what you have saved inside your body. Again, with that tidal in there. And again, there's a little bit more in there if you decide to get rid of all of this, all right, getting down to that area. There's your vital capacity. There's your total lung capacity. Again, this determines change based on whether you have damage to it, smoking, all that other kind of stuff. Cancer is another big thing we'll talk about with this as well. getting into these capacities. So respiratory sounds are monitored with a stethoscope. All right, we used our stethoscope in class before. You've been with doctors who've put it on your chest and on your back and that kind of stuff. And what they're simply listening for is your bronchial sounds, the sounds of the air rushing through the trachea and the bronchia, vesicular breathing sounds, soft sounds of air filling the alveoli. So when they reach down into the base of the lungs as they're putting the thing near your body or back and things like that, they're looking for the vesicular breathing sounds. When they put it up near the top, they're listening for the bronchial sounds. You want it nice and smooth. You don't want any liquidy sounds because that means you have pneumonia. You don't want any harsh things because the stuff's not getting in the place that it should be. Okay. External respiration, oxygen movement into the blood. So this is the next category. After you get from the lungs, now we're going to get it into the blood. Alveolar always has more oxygen than the blood has. Oxygen moves by diffusion past that air-blood barrier towards the area of lower concentration. Pulmonary capillary gains that oxygen, takes it throughout the rest of the body. Carbon dioxide is then picked up, moved out of the blood. Blood returning from the tissues has higher concentration of carbon dioxide than the air. And again, it's all concentration diffusion based. So there's more oxygen coming in than the blood has, so that goes to the blood. There's more carbon dioxide in the blood than there is in the lungs, and so it deposits on the other side. Pulmonary capillary picks up this carbon dioxide.
Attention maintenance staff, please get your
blood leaving the lungs.
Into the payroll information.
Sorry about this.
In your respective offices by 11 o'clock. Thank you.
Blood leaving the lungs is oxygen rich, obviously, and then carbon dioxide poor as the blood is leaving the oxygen. Okay, just don't think about the air. Oxygen transport in the blood inside red blood cells that attaches to your hemoglobin. It's iron-based thing that can hold on to 4 oxygen molecules as it goes through there, and a small amount is dissolved in the plasma. So there is a little bit of oxygen in your plasma as well. Okay, carbon dioxide transported in the blood, most is transported in the plasma as the bicarbonate ion. So what happens is the blood dissolves that carbon dioxide that's supposed to try to hold on to it as the blood cells pull in and turns it into the bicarbonate ion, HCO3 -1. Again, that's just simply combining water and CO2 makes HCO3. Small amount is carried inside the red blood cells on the hemoglobin, but at different binding sites. So the idea is that the hemoglobin really does let go of the oxygen. It really does pull in some of the carbon dioxide, but the rest of the carbon dioxide, that's waste products from your muscles and things like that, has to be transferred into the blood, and then the blood then gives it back to the lungs, all right, at different binding sites. Okay. Internal respiration, exchange of gases between blood and body cells, an opposite reaction happens in the lung. Carbon dioxide diffuses out of the tissue into the blood. Oxygen diffuses from the blood into the tissue. So now you get down to the muscle cells, down where you need the stuff in the mitochondria for all the kind of things you need to do. We're still using high concentration to low concentration, all right, for internal respiration. Okay, so here's a picture of how this kind of stuff works out. All right, so as we get into the internal respiration part here, all right, the bicarbonate ion, this carbon dioxide, whatever, gives the carbon dioxide back to the alveolar sacs to take out. Here's the oxygen coming through, and it's going to be attaching to the hemoglobin. So here's the stuff inside the plasma. Your CO2 and the water have combined to form carbonic acid, which is that bicarbonate ion. It then gives it up in here. This is going to be crucial for your body to know when you need more oxygen and when you don't. This is where hyperventilating really is going to come into play. Again, we'll talk about that later on with conditions that we look at. Okay. Now, we come into this. Here's the tissues. So this summarizes the last 2 types of respiration here. So the oxygen gives itself up to the tissues. Carbon dioxide is given back up to the plasma. Again, reacts with water to form your bicarbonate ion. Okay, and all this takes place inside the plasma cells themselves. All right. So here's a summation of all the stuff that we talked about, where it happens, where it is, how much air is there. Realize that you do still have some oxygen left in expired air. That's why CPR works, mouth-to-mouth resuscitation, even though we really don't need to do that anymore. You really just need to keep the heart pumping and keep beating on the chest. You keep beating on the chest, that keeps changing that pressure and allows air to come in. You get put more oxygen out. But the idea is that if you didn't have any oxygen in there, mouth-to-mouth would have never worked. Okay, so this is just a summation of all the stuff we just talked about, and look at the chains or where oxygen and all that kind of stuff is coming from. Okay, now how is this regulated? Okay, we will start here in a second.